looking to the future. So this discussion is going to explore the underlying challenge of healthcare reform. We'll consider how organisational leadership can improve and give senior leaders at the conference a chance to share their views on the future of the NHS. I'm going to welcome all our speakers to the stage, and then they're all going to speak for a few minutes. Anna Quigley is Head of Health and Social Care Public Affairs at Ipsos UK. Isabel Hardman is Assistant Editor of The Spectator, and she's written a very important book about the history of the NHS. Matthew Taylor is the Chief Executive of the NHS Confederation, and Professor Carmela Hawthorne is Chair of the Royal College of Practitioners. Please welcome them all to the stage. And I know that, Anna, you're going to be speaking from the lectern because you've got some slides to show us as well. And we have a very useful clock on the front of the stage to have everyone. So, Anna, if you want to go for it when you're ready. Thank you.
Hi, everyone. Lovely to be here today. As you've heard, I'm Anna Quigley. I lead the Health and Social Care team at Ipsos. And we do a lot of work talking to the public about the NHS. So I'm going to share some of that with you today. First, though, I think it is worth reflecting on the wider context. We are living in challenging times. Many people will feel this. They'll recognise a polycrisis. They will see political instability. They're seeing the effects of climate change. They're living through a cost of living crisis, and they're seeing wider economic crisis as well. And they are worried about what that means for the country and for its public services. And they're not reassured by government policy on those public services. So you can see, in fact, 7 in 10 people disagree that this government's policies will improve the state of Britain's public services in the long term. And you can see there's a really clear story there over the last decade or so, when that feeling has been getting stronger and stronger, and those two lines have been diverging. And they're worried about the future as well. 6 in 10 say that things are going in the wrong direction. We're generally a pretty pessimistic bunch anyway, but I still think this is a very clear story. Again, you can see how those lines have diverged over the last few years. You can see actually where there was a little bit of hope when more people started to think things were going in the right direction, and I think that was when we were sort of coming out of the pandemic and people started to be a bit more optimistic. But actually, as we've moved on, they've become more pessimistic again. And the NHS is one of the services that they really worry about. Every month, we ask people what are the most important issues facing the country. And the NHS is always at the top, or one of the top. At the moment, it's third. It's behind the economy and inflation, or it was in October when we last asked this. It does rise to the top sometimes. There are peaks. They are usually either when there's nothing else really to worry about in the country, because the NHS is a perennial issue, or they are when something has gone really, really wrong in the NHS and it's made headlines, or, as you can see on this chart, where we've plotted elections. So obviously, in the run-up to an election, the NHS gets talked about a lot more, doesn't it? And we will be entering a pre-election period at some point soon. But this time, it coincides with satisfaction at an all-time low. So at the moment, 2/3 of people say that the standard of care in the NHS has got worse over the last year. And again, you can see that clear story, that progress on that line. And again, they're worried about the future. So over half say that the standard of care will get worse in the next year. That has come down a little bit. It peaked at 62% last year. We'll have to see what happens with that, but it's still over half of people saying that they think things are going to get worse in the next year. And in fact, when we talk to people around the world, Brits are the most likely to say that the healthcare system in their country is overstretched. That's us right at the top. So 83% say that. And that compares with a global country average of 56%. So much more pessimistic, much more worried about the healthcare services that they're seeing in their country. Having said all of that, the public still love the NHS. They still believe in it passionately and remain committed to its founding principles. In fact, 7 in 10 people say that the NHS is crucial to British society and we must do everything we can to maintain it. And you can see we tracked this for many years for DH, and it hasn't really changed that much. We've started tracking it again more recently, and it's still pretty much where it was 20 odd years ago. We did see a little bit of a dip from last year to this year, so we'll have to see how that goes, but still, over 7 in 10 people are saying that we must do everything we can to maintain it. So what does that look like? First of all, it means more money. 8 in 10 people say that the NHS needs an increase in funding. There are political differences in that, in the way that you might expect, but still 8 in 10 people overall think it needs an increase in funding. Where do they think that money should be spent? Staff, mainly. They want to address the pressure on staff, increase the number, address the workload. And that's because when you talk to people about the NHS, they are very, very strongly committed to the people who work in it. They really believe in those people and care about them and care about how well they are doing. But also, it's because it's linked to the other thing that they're worried about, which is access and waiting times. So there's a belief that if you have more staff, then waiting times will come down. So that's why they want more money put there. However, it's not just about money. There is this growing realisation that you can't just keep throwing money at something. When you talk to people qualitatively, and we've been doing this recently about the future of the NHS in workshops around the country, I'm hearing much more than I used to hear over the last few years that perhaps the NHS that was created and came into being 75 years ago isn't the one that you would design now if you were starting from scratch for the population we have at the moment and going to have in the future. And I've not heard that from people quite as much as I'm hearing it now. So they think, yes, it needs more funding, but it also needs to make changes to the way in which it runs. And actually, we're also seeing possibly a growing acceptance that the model needs to change as well. So you've got a quarter of people who say that in 10 years' time, healthcare will generally be free at the point of delivery as it is now. But you've got over half saying that they think we'll have to pay for some services that are free at the moment. And that's something that they don't necessarily want to happen, but they are grudgingly accepting that maybe that is what's going to happen in the future. There's also a recognition that the NHS can't solve all of its own problems. When you ask people what will make the most difference to the NHS, how will it address the challenges it's facing, actually the thing that they are more likely to say as a priority is increasing capacity in social care. They get that dependency. And we also hear a lot from them about the importance of prevention. So when I'm doing these workshops and talking to people, these are the sorts of things I'm hearing. So don't make rash changes. Think about the long term. We want the NHS to be there for our children and our grandchildren, and we're willing to make changes now to enable that to happen. And that includes doing things in slightly different ways, so using services in different ways. Things like virtual wards are one of the examples that we've talked to them about, but lots of others as well. And they're generally really positive about them. They sometimes worry about people being left behind, or they worry about the practicalities of how it will work, but they're really keen to embrace change and do things in a different way. So how would I sum up the mood of the public about the NHS at the moment? I think I'd say they're concerned, they're worried about it, but they're not disillusioned with it. They want to maintain it for the future, but that doesn't mean that they want to preserve it exactly as it is now. So thank you for listening. I'm looking forward to hearing what the panel have got to say.
Thank you so much, Emma. So the other 3 members of the panel are going to speak for 5 minutes each, up to 5 minutes each, from where you're seated, and then we'll have a discussion and take questions from those of you in the audience. So start submitting them online, or we'll have time to go around the room. Isabel Hartman next.
Thank you very much for having me. Thank you so much for that really interesting presentation. I think it really underlines that voters do not have the simplistic views on the NHS that politicians often patronisingly assume that they do. And I think in the past, probably in the past sort of 3 or 4 years, we have seen a maturing of the political debate over the NHS. You know, 10 years ago, when I was covering the debates around the Health and Social Care Act, and Andy Burnham and Jeremy Hunt were at each other's throats over the dispatch box in the Commons, the debate was all about the Tories having a secret plan to privatise the NHS, and very little about the issues that were actually affecting the NHS. And I think we have seen a move from both parties towards a better appreciation that voters do, as you say, love the NHS, but worry about the way in which it is manifesting itself a lot of the time in their lives. And so we've obviously seen, I did prepare for this conference with some deep insights into the inner mental workings of Steve Barclay, but sadly they are no longer important to anyone unless you're a DEFRA. But I would say that Victoria Atkins is a minister who I've always found hugely impressive, somebody with a huge amount of empathy, who was very well respected, particularly when she was Victims Minister, for actually trying to understand the sector, for not shouting from 100 miles away about how you should organise your staff, but actually wanting to listen to people working within the sector. But I suspect she will also not be somebody who will shy away from difficult truths. Don't forget, this is the minister who took Boris Johnson aside when he was, I think he was Foreign Secretary at the time, in front of all of his colleagues in the voting lobbies in the House of Commons, and read him the Riot Act for his comments about spaffing up the wall on child sex abuse cases. So she's not afraid to stand up to people, even if they seem quite big. And I suspect she will have some home truths for the sector as well. Talking to people behind the scenes, I think there's obviously a concern about resolving the strike action, but I think there's also a concern about whether or not providers themselves are doing enough to care for their staff, whether there are proper wellbeing plans in place, whether staff morale is something that entirely stems from government action. And I think probably there's a great deal to be improved in terms of the way that the government engages with the sector and with NHS workers. That actually stems, I think, much more from Rishi Sunak, who I think it's fair to say is not somebody who's personally passionate about the NHS, and probably didn't spend lockdown knitting rainbows for his window. But
do we know how much he's used it?
Not that much. Yeah. I mean, he did admit that his family was using private healthcare.
Using private GPs.
But I think it's worth looking back, having written a book on the history of the NHS, which is available in all good bookshops, etc. I think it's worth looking back at a Prime Minister who did actually have probably a similar outlook on the health service to Sunak, which was Margaret Thatcher. Not a big fan of the NHS, used private healthcare herself, boasted about using private healthcare because it enabled, in her view, other people to move up the queue quicker. But she was always absolutely terrified of doing anything that would be seen to undermine the NHS. She actually had the power and authority to do that, whereas Rishi Sunak does not have the power or authority to do those big reforms or to, vanquish the NHS. And frankly, if all things go according to the way the runes are looking at the moment, he won't have very much power at all within a year anyway. And it was much more interesting hearing from Wes Streeting and what Labour plans to do. And I think that, it was a really policy-rich speech from the Shadow Secretary of State, but there were big questions still missing. So, he talked about the importance of social care reform. But when I interviewed Keir Starmer at the start of this year, he admitted to me that full-scale reform of the social care sector wouldn't happen until term 2. Now, I mean, firstly, who guarantees there is going to be a term 2? Secondly, actually, the sector can't wait. You guys can't wait that long. And if you're not making it a priority in term 1, then that really concerns me about the depth of commitment to hospitals being able to manage their acute patients and their patients who are medically fit for discharge. And I've got 19 seconds. So his commitment to prevention, again, hugely admirable. But I was here a few weeks ago at the Labour Party conference where Rachel Reeves basically stood on the stage and shouted at the Shadow Cabinet saying, "Don't you dare come to me for any more money." Now, you're not going to get the same amount of funding for acute and for community and preventive services. So something's got to give. And if you're going to try to fund prevention and community better, then that means that hospitals are going to have to close, which, Labour MPs don't like, Conservative MPs don't like, voters go mad about, even if those hospitals are not good quality at all. So I think there's some really big political questions still left to answer for Labour as well.
We'll pick some more out when we have the discussion. That was fantastic, Isabel. Thank you so much. Matthew Taylor will reset the clock for 5 minutes for you as well.
Well, thank you. It's great to be here. And just to say that I think some of the slides you put up were from the work you've been doing with us, and we've been working with Ipsos Mori and with Public First on some very kind of in-depth analysis of a public opinion looking at different sections of the electorate, particularly those people who are slightly wavering in relation to their views on the NHS, and thinking a bit about the kind of language that we need to use, the narratives we need to develop, and also some of our vulnerabilities. You know, for example, the public are very willing to believe that the NHS is dripping with managers on huge salaries. So, you know, the way... No, it's absolutely not. We are an undermanaged service, and of course, you know, most people who manage the health service are clinicians. So, you know, there's a lot of kind of mythology about it. But the point of that is that we need to do a bit of myth busting over the next year as well. I think one thing that is good about the appointment of Victoria Atkins is I think there was a nervousness that in the face of the unlikelihood of the Prime Minister meeting his waiting list pledge, there was a danger that the government would, in a sense, or the Conservative Party would turn on the NHS for its failure to deliver in key target areas. And we sometimes saw bits of that with Steve Barclay, particularly the EDI letter that Wes referred to. My sense, knowing a little about the new Secretary of State and her history, is I don't think that's what we're going to see. I think we're going to see somebody who wants, as far as possible, to keep the NHS out of the headlines and to work, I think, with us to see what progress can be made over the next year. That's what I hope, at least, because I think it's been difficult having this sense of a government that is kind of mainly committed to working with us, but sometimes seems to be determined to blame us for the challenges that we face. I think the one thing I just want to make one point, really, which is to focus on the opportunity that we've got over the next year. And that's partly an opportunity to work with the new Secretary of State, who I hope will adopt a slightly more kind of inclusive, collaborative approach to change. But I also think that Wes outlined something really interesting in his speech. My view, and this might sound rather abstruse, kind of abstract, but my view is that the NHS fundamentally suffers from two characteristics of the English state, which is that firstly it's too geographically centralised, and secondly it's insufficiently joined up. And these are two sides of the same coin. It's partly because Whitehall does so much that it's so poor at joining up. And what we're trying to do in the Confed is to kind of model in the ways in which we work what a different NHS would feel like. So on the one hand, that means investing a lot of time and energy in improvement, demonstrating, as I think local government has done, that improvement can come peer-to-peer, that it doesn't have to come top-down, that one can have a more inclusive and collaborative approach to change. I'm always surprised at how little time NHS leaders, how little time you have to actually spend looking at what your colleagues are doing, visiting them, observing them. So I welcomed that element of Wes's speech, which seemed to be around recognising the importance of a kind of horizontal push for change, not just a kind of top-down one. I think systems improve most dramatically when you combine top-down, lateral and bottom-up pressures for improvement. That's when you get real dynamic change. But then the second thing is what Wes said about that mission, about joining up. And we've been reaching out to bits of Whitehall. There's some announcements in the wings, I think, around how they can work with systems and with trusts around the kind of broader health agenda. So I kind of, I think when you look at the election, the politics, you can kind of sit back and say, well, look, I can't control any of that. It's all going to hit me. But actually, I think we can, over the next year, take the future into our hands slightly. And that's by demonstrating the ways in which we can work effectively together so that a new Secretary of State of whatever party can see how the system itself is generating that capacity for improvement, and how also, working particularly at system and at place level, we're starting to forge those links, because in the end, as we all know, the NHS cannot solve the health problems of this country unless we have a proper holistic approach to health. So, you know, I think I don't underestimate the enormous pressures, the day-to-day pressures you're under, all of you thinking now how to respond to the letter you got last week. But I do think there is an opportunity over the next year to start to reimagine how we might govern and lead the NHS if we are going to create the kind of better future that Wes was describing.
Fantastic, Matthew. Thank you so much. And Professor Carmela, is it Hawthorne?
No, it's Hawthorne.
It is Hawthorne. It was a mistype.
Yeah, like a bush
Thank you.
with an E on the end.
Excellent.
That's what I always say.
Over to you.
Yes, Camilla, that's my name. Yeah.
Sorry, forgive me.
So I'm chair of the Royal College of GPs. I'm a working GP in South Wales. And so I feel the heat as much as any other clinician working in the NHS. And I want you to have a picture in your head, first of all. You've all been watching the news, I know. And you know that we always say that that general practice is the bedrock of the NHS. Have a think about that town in Iceland and think of its bedrock and the cracks that you've seen opening up in those streets. And with that, I want you to picture that in September of this year, general practice in England saw 32 million cases, 32 million patients. That's 6 million more than it saw 3 years previously at the same time of year. So in fact, the workload is increasing dramatically, but at the same time, the number of GPs is reducing dramatically, despite there being more trainees than there were before. So we're now 950 plus full-time equivalent GPs less than we were at that time before COVID struck us. So in that case then, I'd like you to add to your Icelandic picture of that river of magma that is flowing for 8 miles underneath the town. That river is the river of GPs who are leaving general practice. Often, well, they're leaving in early, mid and late career. But the late career ones are the ones that I really wish well, I wish none of them were leaving actually. But you know, those are the ones that have all the experience, expertise, and clinical nous that really they need to be able to share with the younger ones that are coming in large numbers. So looking ahead though, I was asked to talk about the future of general practice. Where do I see the vision for general practice? Where we would like to see the vision for general practice in 10 or 15 years' time is as a revitalised profession with a manageable workload, higher retention rates and job satisfaction. And with that, we can actually give our patients the level of care that we need to give them at the top of our licence and in accordance with our training. 2/3 of our GPs currently are telling us that they haven't got enough time to be able to see patients safely. And that's not good, particularly when, if you're on call, you may be asked to make decisions of up to 70 or 80 people in the day, some of whom might be really very seriously ill, and there's always a risk that you'd miss something. So delivering on the vision that I've just given you, don't forget about Iceland just now, about the revitalised profession, what might it look like? These would be really highly trained professionals who are dealing with an ageing population with a high load of chronic disease and multiple chronic illnesses actually. So it's complex medicine, complex pharmacology for all the medications they're on and all the complications from those. Those GPs would be working, supervising and leading quite large teams, multidisciplinary teams, and working in an integrated way with social care, with third sector organisations, with secondary care, and with community voluntary organisations to provide localised targeted care for their communities. They know their communities, they understand their communities. But in order to do that, we really need to move towards something that is much more collaborative, high trust, lower regulation, less time spent in bureaucracy, less time spent trying to pick up pieces of unfortunate patients who get lost in the jungle that is currently the NHS, so that we're then freed up to be able to do that work that we need to do to care for patients in the way that we've been trained to do. And also to give us room to innovate and improve, because GPs are very adaptable. They can innovate. Some GPs are doing fantastic work, but it's in pockets across the country. And Wes was talking about one example earlier, but there are many more. And so we do need to be able to give people the time to be able to not only share good practice, but learn from each other and deliver for our patients. Thank you.
Fantastic. Thank you so much, Camilla. I wanted to ask just one or two questions, and then I've got a couple have already come in online, and we'll definitely get to the room as well. We have a good amount of time for discussion. The first question, just a quick follow-up with you, Camilla. You mentioned the number of GPs, particularly late career, who are leaving. What's the short answer to why they're leaving?
Workload, workload, workload.
And with that, there's a general question about staff retention, which has been a challenge throughout the 2 days of this conference. I wonder what everyone's thoughts are about how we should be thinking about tackling that realistically, both over the next year and in the longer term, because there's been this discussion about the numbers of, for example, doctors going into training, but the amount of time it's going to take for them to come out the other end, and then the fact that many do leave very early, whether they relocate or they leave the career. I don't know if you want to go first, Anna, on this.
Yeah, I was struck by something that Wes said in his speech when he talked about people want to work in, a successful organisation. They don't want to work in a failing organisation. And I think that's really important. It's that morale. And I know from work that we've done that, yes, patient satisfaction is lower than it has been, but that's largely around access. It's not around the quality of that interaction with staff. And I'm not sure if staff feel that they are able to maintain sort of that level of quality of care that they have given in the past. Patients aren't necessarily saying that it's dipping. It is about access when they talk about satisfaction. But it's sort of reminding staff that they still are providing that quality of care. But I also hear everything that we've just heard there, that staff genuinely are worried about the care that they're able to provide and whether it's safe or not, and that's got to be at the crux of it for me.
I'll bring in Isabel and then Camilla and then Matthew.
Yeah, so I mean, I think one of the things that Westminster has really underestimated is the level of trauma within the NHS that hasn't been resolved after COVID. And I think because we have this impression, I think really crafted in school where we, we meet the people who are going to be doctors and they're also like captain of all the sports teams and playing like 3 instruments at once, and they seem like a different species of human. So we expect them to sort of react differently when, even when actually they're so used to a different level of human experience. They see people die, they have to certify their bodies and so on. So you get used to sort of causing pain as well as part of your treatment. For actually them to have an abnormal experience in COVID that traumatises them, I don't think we, as a sort of political world, really understood that. And it really came home to me when I interviewed medics for my book about how they felt 2 years after 2 years after the first lockdown, 2 years after they treated some of the first COVID patients, and none of them had had a break. And they all talked about the first time they cried in front of their juniors in the whole of their career being during COVID. And they'd had, a week off to decompress. Now, I'm actually on a week off at the moment, so it's obviously going really well because there was a reshuffle and this is my spa day. But, anyone who takes a week off from a busy job knows that you don't actually get to the end of that week feeling at all relaxed. You do your laundry, you go to an NHS conference, you don't actually decompress from a major pandemic where your experience of death was far above what you're used to in ITU or infectious diseases or whatever. And I think that ingredient within the strikes has not been understood within Westminster at all, that actually, as much as it's about pay, it's also about people feeling completely and utterly mistreated, ignored, exhausted, desperate to get their voice heard one way or the other. And so, even if Victoria Atkins is given much more licence than Steve Barclay was to resolve the industrial action, and I do think, the point I made about Rishi Sunak, I think he has huge frustration with healthcare workers still striking, and my understanding is that he was responsible for the consultants' talks falling apart when they were about to reach a resolution a few weeks ago, because he sort of swooped in at the last minute and said, no, this demand that they're making is extremely sort of niche, is unreasonable. So, as much as that might be resolved, you'll still have people who are exhausted, people whose workload is unacceptable, people who, said to me repeatedly that I've gone from feeling like I'm giving the basic level of care to people to feeling like I can't do that, even that, on a daily basis. And the long-term impact of that in terms of compassion fatigue, in terms of becoming immune to the sound of pain, is really, really troubling, I think. And I can completely understand why people are quitting. And, you know, it's a nightmare for you guys to have to handle this, because the solution to that in most cases is more staff. And where do you get them from? You can't, you know, COVID showed us that you can flat pack hospitals, but you can't flat pack staff. But I think anything you can do as providers to ensure that your workforce actually have the space and respect, and, you know, they can get time off. They can actually guarantee they're going to get time off for their wedding and that kind of thing. The number of medics and nurses who said to me, oh, my rota doesn't come out until like 2 months before, and so I don't know whether I'm going to have my wedding day off. Just little stuff like that that feels like they're actually being treated like a human, I think is so important.
Thank you. Camilla.
So, yes, you can't flat pack people, can you? But what you can do is put in some really beefy retention schemes that will enable them to stay, make their lives worth living, really, make their jobs worth doing. There are a number of these schemes around. Certainly, obviously, I know about the ones in general practice. There are schemes for newly qualified GPs who are leaving in droves, schemes for mid-career GPs who are also leaving, schemes for late-career GPs, but they're patchy, they're ill-informed. Often GPs don't know about them, and by the time they may find out about them, it's too late. They've already decided to go. And I think that really what we should be doing with the long-term workforce plan, which is promising us double the number of medical students over the next few years, increasing the numbers of GP trainees by 50% over the next few years, but that's going to take 10, 15, 20 years to come through, by which time, if a quarter of our GPs say they're leaving, they're going to be coming into a wasteland. So what we must be doing as well at the same time, and there was a little bit about retention in the long-term workforce plan, but almost nothing, no detail, so high level. Whereas really what we need is somebody to swoop down and actually really get a grip on this and sort out retention, both in secondary care, because it's a problem in secondary care too, but certainly in primary care, where, as I say, the river of magma is flowing.
Matthew, your thoughts?
Yeah, it's difficult in a way, because I think Isabel's right that there is a high level of trauma in the health service, and the very specific and challenging experience that people went through during COVID. And I hear that everywhere I go and speak to leaders. But I also think that, you know, having good work, having been my specialist subject a few years ago, that in the end, I don't think that health workers are any different from other workers in terms of what they value in work, which is, you know, decent paying additions, flexible work which they can build around the rest of their lives. I think it's partly about, you said it's all about workload, it's also about changing expectations, changing lifestyles, people wanting to work in different ways, not necessarily being willing to have the kind of rather rigid career paths that someone as old as me might have been grown up into. It's about a sense of purpose, and this is really hard. You know, I think a challenge for all leaders is, when you're facing huge pressures, still encouraging your staff to feel that actually you can make a difference within the institution, that you're not simply a kind of cog in an enormous machine, but that you can make a difference. And I get, when I talk to leaders, you know, most leaders I speak to, I find inspiring, but there's something particularly inspirational about those leaders who say, look, in the end, I am in charge of what happens within my institution, whatever else is going on around, because you need to hear that, I think. And then culture is really important. And again, I think critical to change and improvement is really deep engagement with staff. We know that, and I'm not just saying this because Navina Evans said it to me 2 days ago, but we know that in the end, staff engagement is absolutely critical, both to retention, but also to improvement and change.
Fantastic. Okay, I'm going to bring one more question up from here, and then I'm going to go to those in the room. Just see. Anna discussed a growing acceptance among the public that the level of service which is free at the point of use will decrease in the near to mid-future. To what extent do the panel think that this is a legitimate reality, or more a symptom of political choices and a narrative perhaps put forward by certain media outlets with their own agendas? The idea of people expecting to pay. I don't know if you want to take that one first, Anna.
It's difficult for me to comment on the real subject of it. What I can say is, when we talk to people about it, yes, their views are shaped by what they're hearing. There is a narrative around it, isn't there? But as I said earlier, I do sense a change in people where it used to be, no, the NHS needs to stay exactly as it is, and thinking that it should be doing better. There's an acceptance now that we have changed, and actually it needs to change to adapt to the population that we have now. That doesn't mean that they're willing to accept this, and I do think that, yeah, their views are shaped by what they hear, and there is. But is that a bad thing? I suppose one of the things that I often think about is we do need to have quite a grown-up conversation with the public about what can you expect from the NHS? What are your priorities? And this is something I'd advocate quite a lot, is, you know, they are ready to have that conversation. We can't continue to do everything that we have done up till now. So let's involve the public in a conversation about, well, which are the things that you absolutely have to have and which are the nice to have, which are the things you're willing to sacrifice. You know, get them to do some of those trade-offs with leaders, with politicians.
Interesting. Isabel and then Matthew and then Camilla.
Yeah, I mean, I think there does need to be honesty about what's actually affordable or the need for higher taxes to afford what actually currently isn't affordable. I mean, I was interested in Wes Streeting's mention of the first test tube baby being enabled by the NHS, because I really disagree with that, actually. The development of IVF happened in a disused operating theatre with the doctors and scientists' colleagues complaining that it was taking away from their NHS work.
They had huge hostility, didn't they?
They had huge hostility,
Lord Winston, I remember.
they had to eventually found a private clinic to go beyond 2 test tube babies. And you know, IVF today is still a postcode lottery. Now, you might say that is how it should be because it's, you know, it's treating infertility, it's not treating a life-threatening illness. But that's a debate that we've never really properly had, even about that. Now, are we going to have a debate about other services that people do consider integral to the NHS?
Are there ones that you noticed when you were researching your book that might be ones people were willing to give up or not?
I mean, I don't know, but I think it's worth reflecting on the fact that people are already paying. They're paying twice a lot of people are now. So they're paying through their taxes and then they're going private, but not because they're loaded like Rishi Sunak, but because they've got a GoFundMe or because they're not going to buy a house and they're going to use their deposit savings to get to the top of a musculoskeletal waiting list, for instance. And you know, this is my real worry, is that you have a slow, stealthy creation of a two-tier system, and then the erosion as part of that of public confidence in the NHS, because people then think, well, hang on a second, I am paying twice, and you know, what am I getting for that? And that was the point at which, in the New Labour years, there was a real fear that the whole system was going to fall over, because if you lose the consent of the middle classes, then boom, that's it for any health system. That was how the NHS came about in the 1940s. It was a problem of access for the working classes, particularly for women who had no healthcare at all. But it was actually also the middle classes who were fed up of paying these massive insurance premiums and who'd seen, through actually mingling with other social groups during the war, that there were other people who were even worse off than them in terms of healthcare. And so, you know, if you start to lose that consent, and if you start to get that irritation as opposed to what we have at the moment, which is people saying, yes, I will pay higher taxes for the NHS, then you reach a really dangerous point in sort of public policy in the health services history.
So you've both articulated the challenge of why people might be thinking that way. Matthew, practically then, what's your view on this question of how far the public are willing to think about things that the NHS shouldn't be covering anymore? Is that something you've already been looking at?
Yeah, so in my speech to Convad Expo, I talked about the 5 things I thought were necessary for the NHS to thrive in the long term. And the 5th point was we need a new social contract with patients and the public. And I think the problem is when we talk about the patients and public having a different relationship with the NHS, we immediately revert to quite niche questions of whether they should pay for missing a GP appointment, or we talk about the money issue. Actually, the more fundamental point is that most of the things we need to do in the health service rely upon a richer relationship with the public. And I think in the future we need to both offer more, but also to expect more from patients. And that's partly a reflection of who are the people who in the end consume the largest resource in the health service. And these are not people who use the health service episodically. They're people with long-term multiple conditions who have a relationship with us. And you know, whether it's, I don't know, anticipatory care or virtual care or shared care or patient-initiated follow-up, you know, a whole number of things we need to do differently in the health service, radically thinking differently about end-of-life care, which is incredibly expensive and still doesn't really work for an awful lot of people. We do need to have that kind of conversation with people, but it's not a kind of we're going to take something away from you, what are you willing to give up conversation, or you've got to pay for something, how much are you willing to pay. It's a much deeper conversation about a relational model of health. You know, my health hero of the year, I ought to say an NHS leader, didn't I? But it's not. It's my sister-in-law who was told she was on the kind of cusp of getting type 2 diabetes and from what I could see, ate nothing but soup for 9 weeks, you know, and kind of lost a lot of weight, started doing, you know, couch to 5K. You know, it's fantastic. I asked her at the end of that, I said, if you've been asked to mentor 3 other people to go through the process you've just been through, would you do it? And she said, I'd have loved to have done it. You know, or if I look at something like the really interesting evidence of the value of mental health peer counselling, you know, I know it can sound trite, but we have to see patients as our greatest asset rather than the kind of thing that's dragging everything away from us. Because if we can have the right kind of conversation with patients and the public, I actually think we can, that's part of how we create a better service.
Such an interesting idea. Camilla.
So yes, there are GPs doing exactly what you say. So David Unwin, who's up here in the northwest somewhere, is doing this with his diabetic patients, and a significant number of the people on his register are not on any medication at all now because they've lost so much weight. But it takes time. And time is a resource in itself. I think, though, coming back to patients and are patients paying, they already are paying, aren't they? They're paying in waiting, they're paying in pain, but they're also paying for those medications that they feel they can afford and not get on prescription. So that, you know, in the past, almost everything you got on prescription, whereas now patients are picking and choosing what they'll take their prescriptions to the chemist for. They're paying for dentistry, or rather they're paying by not going to the dentist anymore. So there is paying going on already. I think we do need to have an honest conversation with our public about how we pay for these things, because they do have to be paid for if we want people, you know, not to have, you know, it used to be your 21st birthday present, wasn't it, to have your teeth extracted. We don't want to be going back there anymore, and yet I see it in the practice I'm working in, which is deprived, in a deprived area, and I see patients struggling to pay for things that they can't really afford at all. And yet then suddenly you hear Boris saying that he's got 40 million for 36 new hospitals, and you think, where did that come from?
Yeah. I think there's something we can learn here from local government. So, you know, trust leaders, system leaders are working much more closely with local governments. Not easy, and often not an easy relationship at system and place level. But look, local governments had no money for so long. They've had to make difficult choices. They've had to have difficult conversations with the public. And I think there's something we can learn about that kind of engagement.
Okay, thank you. Right, questions from the floor. If you could just dim the lights or raise the house lights a bit so I can see a bit better, and wave your arms around. Hopefully new faces want a chance to ask a question. We've got more online, so you don't have to, but if you have got one. Yes, 2 over there, sorry, or maybe 1 over there with 2 hands to direct me to it. Near the back there, thank you.
Hi there.
Oh, and then, was it you? Or was it, there's another one there as well. Right, we've got 2 questions in that row, thank you.
Imran Elahi, Barking, Havering and Redbridge, NHS Trust. I wanted to ask the panel about something that Samira challenged the Shadow Health Secretary on about patient choice, and just whether there's data or evidence about whether the public do want to access a provider with shorter waiting times, a clinician with better outcomes, or whether they want local services to be as high quality as possible.
Thank you.
It's the latter, generally speaking.
Yeah. I mean, just if you saw Wes Streeting's reply, but it was that in being practical in the short term, you just need to let people have access to the same data that middle-class people have been negotiating.
Yeah. So look, I think it's a slightly more subtle argument in the sense of, you know, I haven't bought a car for 15 years, but if I buy a car, I don't have to go round inspecting all the engines because there are people who like to do that kind of thing, you know, and so I can kind of assume that the market has been shaped by intelligent customers who look at data. So I think the point is it's not that a huge number of patients want to go around looking at, and even if the data was more easily represented, they still want to go to their local service. But actually you need a significant proportion of well-informed, sharp-elbowed people, and that is a legitimate way in which you drive change in any system. You know, I talked, didn't I, about top-down, lateral, and bottom-up drivers of change, and part of what drives change is, you know, customers, and people saying, well, actually, no, that isn't good enough, I will go elsewhere. So I think the vast majority of people will want to go to their local hospital, want to use their local GP, but I don't think we should be threatened by the fact that there may be some who use information to help us, to guide us in a way towards doing more of what works and less of what doesn't.
Anyone else want to contribute on this, Isabel, and then I'll take the question.
A sort of anecdote which illustrates how politicians generally see this in terms of local, which is that in the, not the most recent Hartlepool by-election, but the one in, what was it, 2005, the local hospital was under some kind of threat. And no, this was Hartlepool. The Kidderminster one does inform a lot of MPs' opinions as well. But the by-election team for Labour went to John Reid, who was then Secretary of State, and said, look, this is becoming a local campaign issue for us. Can you just guarantee that the hospital is going to be safe under Labour? And his response was, and with apologies to anyone from Hartlepool who's here, very well, they will have the worst hospital in the country, but they can have it. And he wrote a guarantee for the local paper because that's what the by-election campaign team wanted. So that's how politicians view what the patient choice is to sort of safeguard a local institution at all costs.
Interesting, thank you. There was another question there, yes.
Hello, Harris Sultan, Next Director for Citizens and Future Generations on West Yorkshire ICB. Anna, I'm really glad you mentioned future generations, because when I think of the future, I think of climate change. So, a question for the whole panel. How do you think the NHS can better plan to evolve to meet the challenges posed by climate change, not only in terms of becoming more environmentally conscious, but also addressing the impact of climate change on health inequalities? And also, how do you believe we can prepare for the consequences such as warmer summers, which result in excess deaths and extreme weather events, recognising that future generations, including our kids and grandkids, may face a world significantly different from what we know at the moment if, as an institution and individuals, we don't do our part?
Yeah, thank you. It's a good question. And you certainly we're seeing the impacts of more extreme weather very immediately, aren't we, on the NHS and its demands. Who wants to do it first? Camilla.
So as a Royal College and as chair, I'm allowed to set the strategic priorities for the 3 years of my term of office. And one of our priorities is sustainable healthcare. We're not just thinking about climate change, we're thinking about sustainable healthcare in terms of how we use our resources to their best advantage, how we work with patients, how we try to standardise care, as well as how we practice in a greener way. And we are directing our strategy at 3 levels. The first level is what can you be doing in your practice as a GP? What can you be doing at an ICB or cluster level, clusters of practices? And then what can we be doing at national level in terms of lobbying, significant stakeholders who are making climate change decisions, such as the oil and gas licenses in the North Sea. So that's how we're approaching it, and I hope I'll be able to look my grandchildren in the eye in years to come, and that we won't have all boiled by then.
Thank you. Who wants to go next? Matthew?
All I'd say is that, and this is a challenge around the ICS fourth purpose as well, which is that we've got to recognise that, I'm proud that the NHS, I think, was the first national health organisation to commit to net zero. But we've got to see the alignment between our economic, our social, our environmental responsibilities in the day job. It can't feel like a kind of CSR operation which we put at the bottom of the agenda because we'll never get to it because of the pressures that we've got. So we have, for example, to understand, and I think there's growing evidence on this, how more sustainable policies are actually going to save us money, reduce our energy bills, etc., etc. So I think it's an absolute priority, but we need to do the work of recognising how, by being good social, economic environmental citizens, it's going to enable us also to provide better care and to use our money more effectively.
Cool. Did you want to add anything?
Just gonna
Anna?
say that's certainly how the public see it. That when we talk to them about it, it shouldn't be a separate thing. It should just be part of everything that is being developed now and the ways of working. So yeah, absolutely, don't separate it out, otherwise it just won't get done.
There's a question that's come in which says, we didn't ask Wes about this, but what do the panel think the future roles of NHSE and ICBs look like or should look like to support provision of great care? So how should they and their responsibilities be defined looking into the future? I know ICB is relatively new.
Have I got like 3 hours to talk about that? It's like a really, really big question. Look, I'll answer it in 30 seconds. I think NHSE is doing really deep thinking and quite painful change in genuine recognition of the fact that the centre needs to be different in a world of systems. I think one of the first things I did when I got to the Confed was commission Chris Ham to write a report on the future of the centre in a world of systems. And I think NHSE is changing. I think their capacity to change, however, and this is a reflection of, a point that Isabel made in her, brilliant recent book, is limited by the fact that they are answerable to DHSC, and the NHS has always suffered from political short-termism, and that's, I thought if you're looking at the criminology of it, what was really interesting about Wes's speech is that the first half really spoke to the agenda of people, people like myself and Isabel have been saying, look, we have to run the NHS in a different way. It has to have a different model of change. But then he gets into the kind of league tables and new programmes and and that feels like a bit more like the kind of new Labour model of approach that existed when I was supporting that government. So that goes back to what I said at the beginning. I think we need to ourselves start to model a different way of changing, and the NHSE needs to be able to say to Wes, if he's the Secretary of State, look, we can achieve what you want to achieve, but we can achieve it working with you and with NHSE being an independent arm's length body. We don't have to achieve it by you every time there's a problem in the newspapers issuing a new edict. Now, Wes is talking the right talk on that, but it's up to us to step up to the plate as well.
Yeah. Did you want to add something, Isabel?
Yeah, just to, I mean, I think you're being kind to New Labour, because it wasn't just a matter of issuing a new edict. It was also inviting chief executives in for a coffee on Alan Milburn's sofa, which turned out more to be a sort of hour of being shouted at with some biscuits watching uncomfortably on the table. And I think that the impact of that on the NHS culture, and not just New Labour, the Griffiths reforms under Thatcher and the kind of knock-on impact of some of the management practices that came in at that time, where there might be people in this room who remember some of the new managers, the former administrators who thought that the way to manage was to behave like they were a sort of trader on a 1980s floor, as opposed to somebody working within a hospital. And I think, I have to say, my first book was called Why We Get the Wrong Politicians, and had an entire chapter on MPs, alcoholism, sex lives, and everything else. And the legalling for that was still shorter than the legalling for all the bullying in my NHS book. And so I've covered 2 institutions with very toxic cultures. It's just that people are aware of the one in Parliament and much too forgiving of the one in the NHS. But there is a toxic management culture within the health service. Wes was right to say that changing chief executives doesn't actually make that much of a difference, because it's not individuals, it's something that's pervasive. And I think that has been exported to a certain extent from the political world, from shouty, target-driven culture. But it's there, and it's something that has to be dealt with. And politicians aren't going to be able to enforce that change with very much integrity, I have to say, given the system in which they operate too.
Thank you. Well, my final thought to you in closing then is we know that over the next year we're in the run-up, one way or another, to a general election. A year is a very long time in which we know there are all the issues that there are within the NHS, patient anxiety, concerns about staff burnout and all the rest of it. What are your observations about what people here from NHS providers could and should be thinking about doing? I know there's people at a certain level who will be talking directly to those who might be running the country. But a year in which potentially we're all waiting doesn't seem like a positive use of time. What are all your thoughts about that? Matthew first.
Well, look, I mean, you know, folk here are doing what they have to do. And, you know, I just written a kind of blog with due deference to the Secretary of State with kind of advice. And one of my bits of advice is just recognise that leaders in the health service are doing what they need to do. They don't need to be told to do more or different. They are very, very focused on, you know, getting through winter, addressing their backlog, not just the elective backlog, but the backlogs across the system, and also about improvement and change. You know, that is what they're working on. So, as I said, my hope is that we might have a Secretary of State who wants to adopt a more collaborative approach to change, and I think that is an opportunity and something that we've got to step up to. So for me, the one extra thing we need to do on top of all the other things that you have to do is to demonstrate our capacity to change, and also to final point, to sort out difficult issues between us. That if Wes is hearing different things from ICSs and different things from acute leaders and different things from mental health trusts, one of the things he will feel, which politicians like to feel, is, oh, well, I'm going to have to sort all this out. It is important, you know, and I see Julian there. So, you know, when it comes to our work with providers, you know, let's not focus on the narcissism of small differences. Let's focus on those things we agree about. We agree about the future of the health service. And if there are difficult issues for us to solve, well, let's solve them ourselves. Because if we don't, that will absolutely, because, you know, whatever way to say, politicians do have a messiah complex. And if people come to them and say, well, we don't agree what needs to be done, well, you know, leave it to me. I'm the parent. I'll have to sort it out.
Thank you. Camilla.
Yeah, so I think NHS providers and general practice need to talk more than they currently do. If we are heading towards a future, I think both political parties are talking about more services coming out into the community, whether they're secondary care services that come into the community or new integrated services, it's not very clear as yet, but we ought to be thinking ahead so that we've got our strategies, our plans, our ways of getting to that same place, rather than a government coming in and then telling us what we should be doing, which often isn't really what we want to be doing. So I would suggest that we prepare.
Anna, your thoughts?
So in one way, the public do care deeply about the politics of it, and they care deeply who's running the country and especially what they're going to do on the NHS. But on the other hand, I sort of agree with what's been said, is just ignore that, because they can't wait a year for that to happen. And actually, in their day-to-day lives and in the way that they're using services, and when they go to their GP tomorrow, and they care about what's in front of them at that moment in time. So it's about what's within the power of the NHS at the moment to fix and to try to improve or to stop getting worse. Just, focus on those little things.
Thank you. And Isabel, final word to you.
Yeah, I think seeing failure and problems as things to confront and be open about, and I know that goes against a lot of the instincts that have sort of been forced upon the system over the past 30 years, but I really think that one of the issues within the NHS is seeing a mistake or seeing even a systemic problem as something that you need to sort of manage away. And one of the worst examples that I was given recently was of staff who complained about unsafe staffing levels on their wards being sent on resilience training, which sort of suggested that it was a kind of figment of their imagination, and if only they learnt some resilience, they could imagine that there were enough nurses on their units. And, you know, that kind of thing doesn't actually help anyone. And so having that kind of, no, actually, we're going to deal with this problem as opposed to hope that no one else finds out, that would be my key bit of advice.
Thank you. Can I just say what terrific panel you've been. Thank you for your thoughtful insights. Thank you for all the questions raised online and in the room. And that was the last session of the conference. So let's give a big thank you to our panellists. Thank you.